Welcome everyone to our first ever broadcast of Revitalize Your Diabetes Program or Business with Proven Strategies. I'm Coach Beverly, and I'm so excited to be celebrating 25 years of my company this year. And part of that celebration is offering a bunch of free webinars, and this is one of them. So welcome. We have people from all over our country joining us today. I'm so thrilled that you're here, whether you're listening live or maybe you're listening recorded. This is our online university, and our online university has been up and running for at least 20 years. And this has been a crucial part of my ability to share this content with you, because live seminars are terrific and wonderful, but people can't always travel. So we're so thrilled we have this opportunity to connect with you over the airwaves. So our online university, we started small and we've expanded to over 50 courses. We have our virtual conference on there. And as part of our free 25-year celebration, we're offering a series of free webinars to say thank you and to recognize all the work you do to provide care to people living with diabetes. Before I start, I'd like to do a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda, and we recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. So what are we going to talk about today? Well, it's the program title, Revitalize Your Diabetes Program or Business, is the first of our legacy series. And you might be wondering, what is a legacy series? Well, it's my goal and my intention to share this content and my lived experiences to future diabetes educators and specialists. So this is my way of giving back our legacy series. So this is the first in this program, and we're hoping for more, because there's so many about you listening today who have acquired knowledge through doing different activities, and you've learned what works and doesn't work. And I feel like sharing that with others is such a powerful way to inspire others and let them know some of the issues that you ran into so that you can help others overcome them. And so this is my commitment to all of you, is just sharing what I've discovered through lots of trial and error, lots of failure, and a lot of successes in my 30+ year career as a diabetes nurse specialist. So we'll be talking about strategies to create and maintain a successful inpatient diabetes program. How do we create outpatient and vibrant programs? Provide inclusive care in rural clinic settings, and building community to grow, sustain, and revitalize. And I think that's really the key to all of this, is building community, making connection, sharing with each other. We want to be generative and let others know what we have done that has worked well, and areas where we would have done it a little bit differently. So when I go through this content, you might want to consider activities that you are thinking about doing, that you've already done or are doing. And if you've already done them, great, write an article about it, spread the word, publish a paper. We want to know. And the thing about it is, diabetes care and education specialists are a gift. You are a gift. We are so important in supporting and giving people with diabetes the best care, making sure that through our advocacy and knowledge that people with diabetes receive compassionate, kind care, and also evidence-based care. So I want to say congrats to the Association of Diabetes Care and Education Specialists, who've been around for 50 years. I've been a member of that organization for 30 years, and I've had my company for 25 years. And throughout that, I'm so impressed with what my colleagues are able to accomplish, what they're doing, and what they share with others. So what is the definition of a diabetes care and education specialist? And this came actually a great article, if you want to read it, from the 2022 National Standards for Diabetes Self-Management Education and Support. I just pulled it out of there because I loved it so much. A compassionate teacher and expert who, as an integral member of the care team, provides collaborative, comprehensive, and person-centered care and education for people with diabetes. And I mean, this is such a beautiful summary of our philosophy of what we do, of how we approach care. And sometimes if you get discouraged, and I'm sure each one of you here has got discouraged when you've been advocating for someone with diabetes and you've got pushback maybe from the provider sees it differently, or maybe with your colleagues or with a person with diabetes who may not be ready to engage in with what we're sharing. All of that can lead to discouragement. And we want to kind of always remember our why. Why am I here? What is my purpose as a diabetes care and education specialist? What am I hoping to achieve? And sometimes keeping this in mind helps me get refocused and recentered, and really knowing that I'm not going to succeed all the time, but I'm just going to keep smiling and moving forward, because what we do, the care we provide, is based on evidence, and it makes a big difference in people's lives. So, as a diabetes care and education specialist, it's not about getting rich. I mean, we're not in it for that. We're in it because we have a compelling desire to improve care for people with diabetes. And we just want to keep tapping into that, knowing that each time we bring something up, we move it a little bit more forward, hopefully, right? That's our goal. Now, there's different ways that we can participate as diabetes care and education specialists. And this is from, again, the same article saying, what are we called to do? Well, these are different areas that you might be focusing in or specializing at different times of your career. So you might be participating in population health and community outreach and providing health fairs and finding out what are some of the inequities or barriers for people getting care. Maybe you're working in a clinic or an outpatient or inpatient setting where you're really engaged with technology. Maybe you're really working on implementing standardized strategies. And I've been very involved in that throughout my career. Wherever I work, there's policies and procedures that we work on updating and improving to make sure we get the best care. And then workforce training. I'm sure many of you are out there sharing this information with your colleagues, being a leader, being a voice to others, reducing fragmentation. That's a big part of what we do. Is, when I see people in the clinic setting, and then I want to make sure that they do see that podiatrist or get evaluated for vascular disease, making sure they see the dietitian. So we're oftentimes, helping build bridges in between care gaps. It's a really important thing that we do, and advocating for others to do that. We help prevent complications. We are involved in measuring outcomes if you're part of an ADA or ADCES recognized program, or maybe you're involved in a research setting. We want to see if what we're doing is working, because if it's not working, we need to take a different approach. And then, of course, we're continually advocating to address social determinants of health and make sure that the care is available and there's equity in the way we deliver care and reach out to our members. And so, throughout my career, I've focused on different aspects of these, and kind of depending on my job situation, but certainly those are our call to action, areas where we move into where we know are going to make a difference. So the thing about providing diabetes self-management education, it has a lot of benefits, and there's so many papers out there and research done that verify that providing DSME improves knowledge, helps lower weight, improves quality of life, reduces mortality, helps people cope better, helps reduce costs because people are more engaged in primary care, preventive services. They're less likely to go to the emergency room with hypo or hyperglycemia. They know how to, self-manage much better because they've received this information, education, help with problem solving, and they're more likely to follow best practice recommendations, which improves outcomes in the long run and reduces mortality and morbidity. We know DSME works. The biggest issue we have is that DSMES is underutilized. Now, this is, right from the data that we have. Only 5% of Medicare beneficiaries with newly diagnosed diabetes used DSMT services, diabetes self-management training, as what Medicare calls it. Private health insurance, only 6.8 within 12 months of diagnosis have accessed DSME. This is shocking because the American Diabetes Association and ADCES clearly state in their position statement that all people with diabetes need to have initial DSME training and ongoing DSME training, and our numbers are so low. So this informs us that we need to do something different. We need to do something more. We need to revitalize our approach to marketing and connecting with people. So let's talk about that. I'll be kind of talking about different strategies that we can use to reach out to community, to individuals, to providers, to help increase engagement in DSME. And the first thing I want to ask you is, what is your elevator pitch? If somebody asks you, what do you do? What are you going to say? And so I put together 2 elevator pitches because I have 2 different roles. I work in an Indian Health Services clinic 1 day a week, providing care individually to people living with diabetes, and they're very under-resourced community with a lot of social determinants of health barriers. So what I do, what I say about what I do is I help people with diabetes get to their best health through collaboration, education, and advocacy. That's my elevator pitch for the clinic. For my company, I coach healthcare professionals to achieve their dream of becoming certified diabetes specialist. So you could say, oh, I'm a diabetes nurse specialist, right? But what does that tell to that individual you're sharing with? It doesn't give them really the true scope and comprehensive actions that you provide every day. So we want to think of wording that matches our values and matches what we do. And share that with others. And you know what? You could try it out. Write up an elevator pitch and try it out on your friends and colleagues and let them know what you do. See how it feels for you. Does it feel natural, or do you need to change the wording? So I would just ask all of you, after we conclude the program today, just to jot down your elevator pitch and try it out. See how it fits and use it when people ask you, what do you do? Because certainly, just using the description of I'm a diabetes educator doesn't really say what all we do. So we want to give ourselves credit. Okay, so this was a great little chart that was in a paper from 2020. And it compares DSMES versus medication. And they actually compared it to metformin therapy. And here's the criteria they use: efficacy. So DSME, medical nutrition therapy, how efficacious is it? It's really high compared to metformin, which is also really high. Metformin drops A1C 1 to 2 percentage points. MNT, DSME can also drop A1C 1 to 2 percentage points. What's the risk of hypoglycemia? Both very low. How about weight? Most people who enter DSMES programs lose weight. With metformin, it's called weight neutral, but some people, because of GI distress, might lose a little bit of weight. What are the side effects? DSME, MNT, no side effects, except for you feel better, you're more knowledgeable, you have more language when you're communicating with providers to help advocate for best care. Side effects, we all know with metformin, can be GI in nature. That's why we use extended release. What's the cost? There can be some out-of-pocket costs for DSMES and MNT, but Medicare covers 80%, and many private insurance companies cover the majority of that cost. So it's generally very affordable. Metformin is also super cheap. You can buy a 3-month supply over the counter, not over the counter, I'm sorry, 3-month supply from many pharmacies with a prescription for about $12. Psychosocial benefits. Wow, DSME has a lot, because many times it's group education. You're seeing other people with a similar condition and similar struggles, and you're like, I got this, I can do this, right? I mean, it helps elevate people's belief in themselves. In addition to knowing about prevention and healthy eating and nutrition and all the activities they need to do on an annual basis to keep healthy. Metformin has actually no psychosocial benefits. So I'm not saying that medication is not important, because it's wildly important, but so is DSME. It is as or more important, because diabetes is a self-managed condition. We want to give people the resources and tools they need to do that successfully. What I thought I'd do then, kind of given this framework of we don't have enough people, receiving diabetes self-management education, and how can we alter that? And what is the benefit of diabetes care and education specialists? I thought I'd kind of go through a history of what I've been challenged with and some things that I've actually been able to accomplish to improve care. So in 1994, I started at Stanford Hospital as a diabetes nurse specialist. And before that, I had, of course, originally worked as a floor nurse, and I got my master's in public health from UCLA. So I had my, my degrees. And then I worked at an HMO doing outpatient education on chronic disease, including diabetes. I got my CDCES. And then in 1994, with that package of experience and knowledge and certification, I applied for a position at Stanford Hospital. And it was I would be the only diabetes nurse specialist for the whole, 200 plus bed hospital. And I'm just like, this job sounds perfect for me. I got hired. And then I realized when I was working on the floor that, gosh, I don't really have that much knowledge about inpatient management of diabetes and these complicated situations. So I got my Joslin manual. I'm going to show you my Joslin manual. Oh, I don't have it. I thought I had it up here. My Joslin manual, and I started reading it at night to just really and enhance my knowledge of diabetes management. And it really did help me a lot. I got more confident, and I devoured the ADA standards. The ADA standards, when I first started in 1994, were about 30 pages, so super easy to read through. And then this last bullet point I think is funny. I tried to appear knowledgeable. So we all have imposter syndrome, and I certainly did. I had my white lab coat, and I was like using that to show people that, yes, I know what I'm talking about. And I remember one provider asked me, what do you think is better, glyburide or glipizide? And I'm like, that's a great question. I'm going to look that up and get back to you. And that was just when the internet was coming out. So I actually had to pull out a drug book and look at like what would be the difference. So I think for all of us, when we first enter these new positions, there's a little bit of, gosh, am I the right person? Do I have enough knowledge? Am I really up for this? Yes, you are. Yes, you are. Because a lot of diabetes, y'all know this, is on the job training. I could have read that Joslin book all day, and still it was the people with diabetes, the patients in the inpatient setting, who taught me the most, right? They're teaching me, oh, this is what happens when we give this much insulin, or if people are on steroids, or if people are, post-surgical. That feedback told me about the body and inflammation and how the body responds and what blood sugars do. And so that on-the-job learning is so powerful, whether we're doing it inpatient or outpatient. And that's how we gain our knowledge, by listening to people with diabetes. And then, of course, we can go back and, read books and affirm our knowledge. But I just want to say that so much of diabetes care is on the job training. So give yourself a lot of grace and credit, especially if you're new to the field. So inpatient management, does it matter? Yeah, it really matters. About 20% of CESs work in the inpatient side. We know that in hospital settings, there's 30 to 40% of inpatients at any given time have diabetes, maybe diagnosed. Up to 5 to 10% of them might not have a diagnosis yet. We know that diabetes is co-associated with cardiovascular conditions, cellulitis, infections. So many times it's not the diabetes that admits them, it's a co-related condition that admits them. But diabetes has certainly contributed to them arriving at this point. And the thing is, we can't bill because we're part of the overhead. So we don't get reimbursed for seeing individuals in the hospital. When I worked at Stanford, I would keep track of how many people I saw every day and on what units. And the reason I did that is because many times, since I'm just running through the hospital, people don't really know what I'm doing. And I wanted to let them know that I am accountable to you. Like, I want to let you know how many people I'm seeing a day, what floors I'm seeing them on, and what services I provide. And by doing that, then people know, as specialists, what are we doing? Because we know what, the staff do that work there on the floor on a regular basis. That's very clear. But for us that work as specialists in a clinic or inpatient setting, it's helpful for individuals or colleagues to know what we're doing and how we're contributing, writing it down. All right. So getting back to, does inpatient diabetes education work? Yes, it provides a unique opportunity to connect with people with diabetes to support behavior change. Because like I said, it's probably their diabetes that has brought them to this point, this other condition that they have. So there's a certain vulnerability that we might be able to connect with when we're sharing education. and saying, gosh, this must be really hard for you. I know you're in a rough spot. Do you want to have a conversation about your diabetes? I really want to help you manage it to the best of your ability. I'm going to tell you that many times other providers might say to people with diabetes in the hospital, if you don't get your diabetes under control, these things are going to happen to you. There might be some scare tactics being used. So we're going to come in with a different approach and let them know we're on their side. We know this is a struggle. We're here to help, because shame and blame really closes people off. So we're going to open doors instead of close them and let them know, we know this is a challenge. We're here to help you. Okay, so when I started at Stanford, they said you have 1 year to demonstrate that I could save as much as my annual salary. So I go, okay, how do we do that? And they go, well, we put together the research team and we decided we would draw A1Cs on admission and then A1Cs at discharge to see how much your intervention would drop the A1C. And I went, we might have to rethink that, because A1C is a 3-month measure. So that's why it's so great that as clinical experts, we're involved in research so we can make sure the research studies are set up correctly. So instead, we shifted to glucose levels. We measured what their blood sugars were on admission, during their stay, and at discharge. We looked at our rates of hypo and hyperglycemia, and we looked at length of stay for people with diabetes diagnostic codes. And certainly we saw that people with diabetes had longer lengths of stay, and many times discharge was delayed because of elevated blood sugars or too low of blood sugars. So we documented and shared this, and we found out that through our chart audits, 50% of people with diabetes in the hospital had elevated blood sugars of 200 or greater. Okay, good. So now that we have our data, we can take action. And I would encourage any of you working in a hospital setting to gather data about what the blood sugars are running in your hospital. And we can do that so much easier now through electronic medical systems and with our IT department. And those days we had to actually pull physical charts. But the point is, in our hospital, there was no standardized insulin approach. So this is 25 years ago, or a little bit more. Okay, so 28 years ago. And what would happen is the attendings would just tell the interns a scale they learned from their attending. So it was just like these scales that were kind of random. Sometimes there was math involved, like blood sugar minus 100 divided by some denominator. And so it had a lot of potential for error. And there's all these different scales floating out there. And pharmacy was so tired of typing in all these different scales. The other thing is that blood sugar management was not perceived as worthwhile. The providers might say, well, it's just a few days of elevated blood sugar. But the truth is, if I'm a person with diabetes in the hospital and nobody's worried about my blood sugar being elevated, I might feel like, why should I care? And the truth also is that more elevated blood sugar worsens outcomes. So we finally, right around that time, the DSME study was published, and we learned that inpatient management really is important, especially for post-CABG in that example. Okay, there was a lot of transcription mistakes that were happening too, because the providers were actually handwriting the sliding scale at that time. This all led to frequent elevated blood sugars, hypoglycemia, longer length of stay, and people were frustrated. The people with diabetes were frustrated, providers were frustrated because the staff kept calling saying blood sugars are not on target. Pharmacists were frustrated entering all this. Nurses were frustrated. We felt like, we want to make the situation better, and we can't. And so what I did is I went to my Joslin manual, my other ADA books that I had as my resources, and I looked up and I said to myself, is there any standardized sliding scale out there? And I actually found these correction scales. And so I said, maybe we can use correction scales as a basis to standardize the scales. And what I did then is put together this template, and I called it regular insulin sliding scale. Our goal is to keep blood sugar 70 to 200. We would modify that now, maybe more 100 to 200. It should not be used for more than 2 days as the only method of glucose control, knowing that we needed to add some basal insulin in or figure out a management plan that really works. So this was kind of just a getting started standardized measure. And I created these 3 categories: mild, moderate, and aggressive. And you can see if the blood sugar is less than 150, no insulin is given. But once it starts hitting 150, we consider for moderate individuals average weight and eating to give them 3 units, or if they're on steroids or infected, we would give them a little bit more. We also created a night scale because we were having a lot of overnight hypoglycemia, because we were giving a lot of insulin before they went to bed at night, and they oftentimes didn't get that bedtime snack, and they were getting nocturnal lows. So you can see this is from 1997. I actually presented it, an earlier version, at the AADE national meeting in 1996, and people went crazy. The room was full, and so many people came up afterwards and said, I need a copy of that card. So I just wanted to show you. This was the original card here, and on the back it has instructions about insulin administration. And then over time we increased it, the card content, because everybody loved carrying this card in their pocket. And we had the sliding scale on one side, insulin drip on the other side, DKA management on this side, along with insulin information. So it works so well, because when we released this card, it was only supposed to be evaluated on a few units, but pretty soon the whole hospital, the interns and residents loved it so much, because all they had to write on the order set was mild, moderate, or aggressive scale. And of course, we had a copy of the scale in the chart. And then we automated it in the medical system, on the computer system, so that the pharmacists didn't have to input this anymore. And so this was a bold idea. It hadn't been done before. The attendings and residents were so grateful for it. And I want to mention that I did have a little pushback from the endocrine department because it wasn't basal bolus, but I felt really strongly that we needed to start somewhere to just standardize the way we're doing things. So I want to just quote Amelia Earhart here. The most difficult thing is a decision to act. The rest is merely tenacity. And I feel like as diabetes care and education specialists, we're all about tenacity. We're all about advocacy, and there's a lot of potential barriers out there, but we're just going to keep boldly moving forward. And I put down here, don't let perfect stop you. I mean, that wasn't perfect what we created, but it was better than what we had. So it's just a change of thought. It's a change of vision. It's a change of approach. And by opening that door, we can really make more and more improvements that are going to impact outcomes. The other thing is I want to encourage all of us to discover our colleagues' gifts. When I was working on this sliding scale program, I really collaborated with pharmacy. The pharmacist there, the head pharmacist, was so amazing. He believed in it, and he said, I'm going to provide the budget to print these pocket cards. I will train the staff on this. And he said, this is going to improve things so much. So by collaborating with pharmacy, it really helped move it forward through a P&T committee. And it helped give it a little more, what's the word? I'll think of it in a minute, but it just gave us a little more oomph, is what I'm going to say, for legitimacy. We want to discover common goals to improve care. We want to identify approaches that match your values and resonate with people with diabetes. I also team taught with many dietitians through my lifetime. And team teaching with dietitians is magical, because they have so many great ways of describing food and nutrition and making it sound so delicious and wonderful while improving health. Incorporate observed wisdom into your own practice. Oh, I shamelessly do that. I love the way you're saying that. Can I use that in the way I present? So as we, connect with our colleagues, we gain wisdom and approaches that we might not have considered. The thing is, we can't do this by ourselves. The hospital was huge. I was being paged left and right, and there was so much work to do. So we developed a diabetes resource committee, one person from each unit. We met monthly. You can see here's the group here. They were so amazing. They were passionate about diabetes, and we worked on goals together and implementing these goals and sharing information. And we actually created this packet of information with handouts on diabetes. Let's see if I can get to the camera. And also we created a little log sheet that people with diabetes in the hospital could write down the insulin, their blood sugars, how much insulin was given, so that would help them prepare for discharge. we measured outcomes, and we created a program where they could be diabetes Stanford certified. And I just want to show you the little pin. So if they, oh, here it is. Okay. They could put this on their badge. It was so, people loved it. So if they were able to come to a class, they would have to shadow me for a day. They would do assessments. They would do a presentation. They would be involved in research. Then they would get that diabetes certified pen from Stanford. And many of them went on to become CDCESs. So it was a great program, and it really provided me with so much support and an ability to provide care to more people, which is what we're all about. So we're constantly figuring out ways that we can teach others about what we're doing to expand our reach. The other thing is we want to incorporate person-centered care into our messaging and have fun. You know, we would talk about, we have little themes in our newsletter. It's not your fault. Lift the sheets and look at the feet. Guilt-free diabetes education. There's no such thing as cheating. We got rid of that word and recognize the individual's expertise. We had a take control club. We wanted to keep blood sugars at that time 70 to 140. That was before the new research came out. And we would have these little buttons that we would wear. So we want to, you know, invest in building a successful program, whether it's inpatient or outpatient. And we can do that by investing in training and mentoring. Share what you are accomplishing with management and stakeholders. Like I would say, I would keep track of how many patients I saw a day, what units, what other things I was providing. I would share it with the managers of different floors. I wrote a newsletter, which was about once or twice a month. It was just a one-page newsletter sharing what I was doing with the different units. We had the resource committee, we had certificate training program. I was invited to train the medical students and residents about diabetes management, and I got to present at orientation. And the greatest thing is, you know, I presented live at orientation, but then they decided to video me so that they could just show the video and I could present at orientation even if I was somewhere else off campus. You know, the thing about sharing our success, we're not really trained to do that. We're not, sometimes we might feel like we're being braggadocious, you know, sharing what we're doing and highlighting our success or our accomplishments. But I just want to encourage all of you to own your success. You earned it. You worked hard for it. It wasn't easily achieved. So no one will know all the great things you are doing unless you let it be known. Newsletter, reports, email, articles, poster sessions, national conferences, during meetings. Let people know what you're doing, what you're accomplishing. And I would like all of you, as we go through this content, to consider a success that you feel great about. And at the end of the class, this program, I'm going to be reading out loud your successes that you feel great about, no matter how big or small. And that way we can recognize together what we're doing, because I know so many of you are doing great things and we want to hear about it. Well, I wanted to say, for the second part, after 1994, I started at Stanford, and then around 1997, I met a really cute pharmacist at Stanford, and of course he was smart and wonderful too. But we got married. He asked if he can learn more about diabetes. I said sure, and then we got married. We moved up to this rural part of California called Chico, and there wasn't really any opportunities for me to work at the local hospital. So I go, I think it's time to start my own company. I just felt like I have a message I wanted to share. I wanted to do more, you know, workforce training and lecturing, and so I said I'm going to start this company called Diabetes Educational Services, and this is my original brochure. Here's my original headshot. So I'm just sharing it with you. I'm looking at it feeling a little bit embarrassed because it was so basic, but hey, you know, don't let perfect stop you from moving forward. So I just said, I'm going to get it out there and get started. And then I also was at the same time hired to start up an ADA recognized program at a local rural hospital in Paradise. So I was so fortunate I got to work there one day a week while growing my company and growing my own family. So let me just talk about first, when I was working in this rural hospital, we set up an ADA recognized program, and this was our class topics. We divided our sessions into 4 2-hour sessions around that, a little bit longer. And you can see what we talked about. It was taught by myself, a dietitian, and a physical therapist. And even though I was just there one day a week, I had a wonderful secretary. She was there 20 hours a week who could help organize and market and get this information out. Our brochure also listed the months that we would teach this class. And actually, we had pretty good success. We had at least 10 people attend per class, even though it was a small community, but it was challenging. So let me ask you this question. As far as marketing, you've got this great program, it's ADA recognized or ADCES recognized, build it and they will come. Is that true or false? Let me go ahead and launch this poll. Build it and they will come. Is that true or false as far as an ADA recognized or ADCES recognized program? I'll wait a few seconds. Okay. Let me go ahead and close the poll and share your results. So 27% of you said A, 73% of you said true, and 73% of you said false. Yes, so I would have to agree with the B's. We can, or the people who said false, we can have the best program, but if people don't know about it, they're not going to show up and take advantage of that information. So as hard as it is to say out loud, and I wish this wasn't part of our job description, but truly part of what we do is market our services. And it's not just marketing once, it's marketing over and over again, letting people know the services we provide. And maybe you have a marketing team who can help you with that, but in my experience, it really comes from the team, the diabetes education team. Our enthusiasm has to spill over into the marketing team. So we would write out marketing plans for the year, and I still do. I write out marketing plans for the year. Like, when are we going to market our programs? Are there special times of year? Like, we all know that in November we have National Diabetes Month. In March we used to have Sound the Alert Day, where we raise awareness of diabetes. But I would say March and November are pretty key months for diabetes, just raising awareness. But the other thing we did is office visits. We would actually make Thanksgiving card. So every year we would take a team picture, have a Thanksgiving card, deliver it to the different offices along with a brochure of our services that were coming up for the next year and referral sheets. The offices always ran out of referral sheets. So we had a little packet with our label on it, how to call us, how to get more referral sheets, and we just distribute it to the providers. Did that take time out of my day seeing individuals with diabetes? Yes, but it was so worth it, because when we would make our rounds, we would not only hopefully say hi to the providers, but they're usually so busy, but we would meet the front office staff. And when you meet the front office staff and you make that connection with them and, you know, get their names and know a little bit about them, they are really going to help promote your program. So if a person says, oh, I have diabetes, that person sitting at the front desk can say, oh, we have a great diabetes program. So we want to get the news out to as many people as possible and touch their heart, you know, and say, hey, do you know anybody with diabetes? Yeah, it's a tough condition. We have a great program. We help people feel more confident and learn about self-management of diabetes. So we really want to touch them in an emotional way, so they have this emotional connection with us. And that is the way they're going to hold on and remember to refer people. Okay, tally providers, referrals, and share. So what we would also do at our annual meetings is we would tally up which provider, you know, how many referrals they sent us, and we would share that, and we would give an award to the provider who referred the most people to us. So, you know, a little motivation there. CE activities, if we can do those, so teaching others so that they understand our knowledge base and what we offer is so helpful. Hallway conferences, you know, just being out there, getting out of the office, talking to people, how's it going with diabetes, any issues you need to discuss, you know, how's the standard order set going, whatever. Welcome packet for new providers. Oh, this is so great. So any new providers in our area, we would put together a packet letting them know what we do, our referral forms. If we could, you know, meet them in person and do a handshake. Testimonials from participants. This is so important. So I will tell people, if this service feels beneficial to you, if you find that, this information we're sharing has really helped you self-manage your diabetes, could you please share that with your provider? Just a sentence. That was super helpful for us too. And when, participants let their providers know it was meaningful and it was helpful, that really helps to solidify that, yes, what we're offering is very valuable to people with diabetes. Create something to give away with your logo. What we would do every year is we would take those medication pocket cards that I put together, where I have one here, these, and we would put a sticker with our logo on it, and give it to the providers, so that when they looked up medications for diabetes, oh, how handy, we know the number to the diabetes program. But you could create something you want to give away, like a cheat sheet of information, what on sick days, or on a nutrition cheat sheet would be so great. Healthy foods to encourage people with diabetes to enjoy, or something like that. We're just going to try and be real innovative and think about, how do we connect with our community? And I'm talking about provider referrals, but also we want to reach out to individuals directly. I found that to be most successful. Health fairs, events, community presentations. I would ask community organizations, hey, could I come present for you in November, or other months where you have openings, and talk about our diabetes program? We can do emails, we can do social media. Social media is so effective. We can even do little quizzes on social media to attract people. People love quizzes and self-assessment. So you could do that too. See if you're at risk. They could do the diabetes risk quiz online. I actually invited myself to do TV interviews. So I would call our local station and say, hey, it's November, National Diabetes Month, or we had a run for diabetes. Can I come talk to your audience about this? And they loved it. And I always would bring my props. I would bring my pancreas and my DSME. And it was so great for the media, because they just gave a nice visual presentation. You could bring some props too. So radio stations, invite yourself, let your expertise be known. We can reach out directly to the community, and they could call our department, and we could say, hey, thank you so much for calling us. Let me check with your provider. We fax the provider the referral form. They would always sign it. So we can reach out in different ways. And I know this sounds like a lot, but it's so important for the vibrancy and to keep our program alive and generating revenue, because when the administration sees we're generating revenue, and also the community knows about this program, it's such a great representation of the facility to the community that we really care about them. So shine your light is what I really want to say. Attend medical meetings. I would do that once a year, and just share our outcome data on blood sugars in the hospital setting. I would share our graduation rate. I would share the outcomes that people were experiencing with their A1Cs dropping and their weight. They were also many times lost weight and improved their knowledge. Presented volunteer, oh yeah, hospital volunteers or clinic volunteers are very important people, because they talk to community members and they can recommend your program. Create program brochure that connects with your community, and make sure, oh gosh, this is really important. Go to your website of your organization and make sure you're represented accurately on the website. Many times when websites are initially set up, everything's correct, but over time, it might not be updated. So be a voice, see if it's updated. If it's not, see if you can get it updated, because it's so important that we're represented accurately on the website, because that's how so many people find out about us. So addressing defeats. You may encounter many defeats, but you must not be defeated. In fact, it may be necessary to encounter the defeat so you can know who you are, what you can rise from, how you can still come out of it. Maya Angelou. Better words were not spoken. Yeah, so I'll just tell you about a defeat that I experienced, and this is called the billboard defeat. So we, at the hospital I worked at for 20 years, burned down in the campfire. So I would be working there still today if it was still there and providing service, but it had to close. anyways, so we go up this hill to Paradise, and they would have all these billboards for our hospital, and they would have billboards for cardiovascular, for stroke, for cancer, all these other things. So I kept talking to the marketing people, and I said, hey, how about a billboard for diabetes? And they would say, not this year, it's not in the budget. I'm like, okay, well, can you put it in the budget for next year? And they go, we're not sure, Beverly, but maybe we could do some other things. And I kept asking for that billboard every year. Every year they said no, but because I was so enthusiastic about the billboard, they helped me figure out other marketing strategies that would kind of work in place of the billboard. So I just want to say, keep showing up, keep smiling, keep showing up, just keep being energetic about it. Because even though you may not get that billboard, you might get something else in its place, and they know you are there and you're not going away. That's what you want people to know. I'm here. I'm committed. I'm not going away. I believe in this program. This program is terrific. It improves outcomes. I'm going to keep advocating for it. Well, since my hospital burned down, then I had to find a new way to provide care, because I run my company, and it's busy. My company's busy, but I'm completely committed to seeing people with diabetes for my career. That's what informs me. That's what keeps me knowing what's happening. It's so important. So I was so lucky to get a job at a local rural Indian health services clinic, and I worked there one day a week for several years now, and we mostly serve Spanish-speaking individuals, people that come from under-resourced areas, and it's been so wonderful for me. And as I just mentioned, I serve Spanish-speaking individuals. So my Spanish is pretty good. I've lived in Mexico for a while, but it is rusty. Okay, let's just be honest. So as I listen to people who are speaking Spanish, I have to give it my total intention. My total body and mind are dedicated to understanding what that person is saying. And I'm listening to their words, I'm looking at their gestures, I'm looking for those nuances to make sure I gather as much information as I can. And I was thinking about that the other day. I'm like, wow, what if I applied that to people who speak my native language, which is English? I just feel like it's so important. It's really helped me re-engage with that person-centered approach. And it's really also enlightened me to the struggle of individuals who come from different countries, who don't possess English in their language. And it's so challenging to navigate so many aspects of life in America without having knowledge of English, but they still do amazing. Okay, so rural care, it's different, right? And when I started working there and I was kind of listening to the language and the approaches that were used, it provided me with a great opportunity to talk about person-centered care. And instead of saying, oh, we need to provide person-centered care, I would say something like, well, if like some providers would say, Beverly, this person is totally non-compliant, you got to get them on track. And then I would come back and say, oh, you mean this person's on a diabetes vacation and they're really struggling with self-care? And they would be like, yeah, that's what I mean. I go, okay, well, let me see what the barriers are and see if I can support them and, really kind of connecting with their diabetes again. So that's just kind of one example of when people use the more compliant model language, how we can come back and use person-centered language in a real loving, kind way to let them know, oh, yeah, we talk about this different now. Or if they'll say, oh, those are, they're cheating, they're eating all these bad foods, I'll go, you know what, the great news about the way we approach diabetes education now, it's not about cheating, it's about choices. So, I can talk to them about portion size, about healthier food choices, and of course, refer them to the dietitian. So in rural settings, we're going to be advocates. We're going to be seeing people individually. Sometimes we can see people in group, depending on the insurance coverage. But we also want to extend our care out to the community and make sure we're giving them the care that they want and they need. And many times we can build bridges through community health workers that live in the communities and work in the community, but also have knowledge that we might not have as healthcare providers to improve the care, and the way we provide our care can be definitely improved. The other thing is reaching out to those who don't show up. And so instead of saying, oh, that person, just never shows up for their appointment, let's change that dialogue to say, why aren't they showing up? to their appointment. And I think about this a lot. You know, the way our clinics are set up or our hospitals are set up, is it set up so when that person walks in the door, they know they are welcome, that they know that they are part of this healthcare community. We want to always just kind of question and evaluate that. The thing is, we want to focus on what the individual is doing right. And when we do that, they increase their belief in themselves. So we transmit our belief in others through body language, affirmation, and encouragement. We want to use strength-based approach, focus on, what they are accomplishing, which increases their confidence and ability to succeed, not only for that individual we're serving, but for ourselves. Because then we don't have to own it all, right? It's a collaboration. Use phrases like, you've overcome this in the past, and I believe in your ability to figure this out. Our belief in people is powerful and contagious. We want to limit advice giving and expand curiosity. We want to ask the person with diabetes to share their story. And as they're sharing their story, we might be thinking about, oh yeah, I had a person like this and we did A, B, C, and D, but then we're not hearing their story. We need to hear their story and help them figure out how to fix it, right? Because they know them best. And I have a whole cheat sheet on this topic on person-centered interviewing, which pulls in components of motivational interviewing. Because the truth is, the person sitting across from us knows what will fix the situation. Our goal is to help them in the process of self-discovery. Our goal is to help them find the expert within. So we're going to be asking a lot of questions. That's our main goal. If I'm talking a lot, I know that I'm off track. I'm like, Beverly, you need to just ask questions and listen. I was doing a presentation to tribal members as a part of a meeting that I was invited to speak at. And before I started on my content, I asked the members, what prevents you from getting to your best health? And these are people living with diabetes. And they were so clear on recognizing it was a lack of transportation, not enough money to buy healthy foods, no local grocery stores, mostly liquor stores. And they were often afraid of being judged. So people's fear of being shamed in healthcare settings is a big barrier for them arriving. So we want to make sure that we really move away from judgment and shaming and blaming. And we also recognize that when people show up, they're not just that pathophysiology or that individual in front of us at that moment. They have a whole history and a whole environment that they come from, known as the social determinants of health, where people play, live, work, learn, and pray. This social environment directly affects their ability to receive health care and their ability to engage in healthy behaviors, and it can also serve as barriers for all of those. So we're really striving for equity. And equity in healthcare isn't the same as equality. Like if you plant an apple tree down the street, you would say, well, we planted an apple tree, why aren't people eating more apples? So the thing is, equity would say, well, there's a person in one house who doesn't have the ability to walk. They need to use a walker or a cane or maybe a wheelchair and it's too far for them. Or maybe another person, they're not tall enough to reach the apple. So we need to provide a little ladder for them or a way they can reach this fresh fruit and vegetables. That's being equitable. So when we think about it, we might have this service available, but can the person get to the service? Do they have a car? Do they have a babysitter? What are the barriers? Do they have a cell phone? Do they know that, can they get appointment reminders? So our goal is to really address these social determinants of care and make sure we provide equitable care and address systemic racism. Creating an environment where everyone feels welcome. I was talking about this earlier. Unknowingly, we may be creating an environment that doesn't reflect the community we serve. So some ideas are display local artwork, sculpture, vegetation that from their place of origin that they're familiar with and that brings them joy. Handouts that are meaningful to the people we serve. Recognizing when people show up to an appointment. Thank you so much for making this appointment. I know you've got a lot of other competing demands, and you made it a priority to show up today. Oh, swag bags is the other thing. We are giving out swag bags to every new person with diabetes that we see. And the swag bag has lotion, and it has a toothbrush and toothpaste, and it has diabetes socks and other things. Oh, a medication box so they can keep track of their medication. People love it. And that act of giving is so powerful, and they want to keep coming back. You know, really, at the end of the day, it's not about what you have or even what you've accomplished. It's about who you've lifted up, who you've made better. It's about what you've given back. Denzel Washington. Couldn't say it better than that. And that's really what we are. We're about giving back, and we're about discovering our own vision. So in the last part, I just kind of wanted to talk about the journey of my company. And when I first started my company, it was very small. It was, you know, it was in the living room of my house. And then over time, as my company grew, I was able to build an office and really expand the services I provide. But it took time and diligence and hard work, sweat equity, long nights, all of that stuff. So what is my vision? Well, provide training and education for the next generation of diabetes care and education specialists. Guilt-free approach infused with kindness and compassion. So I'm very clear about my values, what I'm trying to work toward, and maybe you've written a statement of your vision and your goals. And it's so helpful to make sure we're going the right direction and that we're on the right path. Because if we get off the path, you could tell something feels wrong. Another big part of our vision of our company is, and myself, is offer free resources and content that is useful in clinical practice and providing evidence-based content without financial support from industry. So these are some of my operating goals and kind of framework that brought me to where I am today. And here's our website. And I wish I had a picture of my original website. It was pretty bad, but don't let perfect stop you. It's my motto. And so I finally found a good web company that I really connected with and said, we want to share your values with your community. And so we put this together, and you can see a lot of what I want to do is share information for free. I want to give away pocket cards. We have our CDCS coach app, which offers a lot of like cheat sheets and our question of the week, our rationale of the week, because I have found that through giving away, through sharing, through this generative approach, the more I give away with loving intention, the more my community grows. Are there ways you can share and give away, or ways you're already giving and sharing and giving away things? And I think the more that we do that, the more that we say, gosh, I have this special knowledge or specialty knowledge, and if I can share it with others, whether it's people with diabetes, colleagues, friends, neighbors, whomever you're giving it to, it creates community and a sense of belonging. And that feeling is powerful. It's knowledge is really important too, but that sense of connection is what humans really, it vibrates with us. It sounded kind of hokey, but there is a certain, you know, that we are designed to connect. So create community through sharing. As you all know, I have the pocket cards, I have cheat sheets, I have stickers, I have bags, blogs, and newsletter. Like I write my newsletter once a month, and I've been doing that for over 15 years. And yeah, everybody knows the beginning of the month, Beverly is not available because I'm like, I got to write this. But here's the thing, it's so important to me that I will push everything else aside to make it happen, because this connection to all of you, this sharing is so powerful. And there's so much important stuff we want to share. Mentoring and support, and then we have our teaching tools. And I just want to say one thing about these teaching tools, talking about connection. Girls in Kenya, women in Kenya, as part of the Just One Person program, sew these pancreases for me in Kenya. And then we ship them over to America. My mom stuffs them. My mom has diabetes. And then Ginger puts these little balls on them, the beta cells and alpha cells, and we sell them. And the money goes right back to the girls in Kenya, so they can go to college, so they can advance their life, so they can, you know, share with the future generations a different way. And I think this is so powerful. Again, just another way that we can connect through community and sharing. So these teaching tools, that pancreas is so powerful. And when I first started my company, I only had live seminars, and we couldn't do any live seminars for 3 years because of COVID, but we're coming back to San Diego in October. We're so excited. October 11th through 13th, and we're not only going to have 3 great days of content, we're also going to have a party on the 11th. And I've expanded my speaking staff, so now we have Dr. Diana Isaac speaking for 2 days, Ashley Lebrier, our dietitian, speaking for 4 hours on nutrition therapy. So it's going to be a great conference, and hopefully we'll keep offering it every year. You know, another way that I really feel great about reaching out is our CDCES Coach app. It's an easy way to access a lot of information. It's free, and it's was designed by Susan, and Susan worked for our company. And one day I said to her, it was about 8 years ago, "Hey, Susan, what do you think about creating an app?" And she goes, "I think I can do it." She never created an app before, and she made it happen without any IT experience. So this is what I'm saying. Have a vision, believe in it, move it forward. Don't worry about perfect. We're just going to get started. And of course, we're so excited about our swag. And you know, the swag is just a way to say thank you to all of you for 25 years of supporting this company. So believe in you. And the last part, I'd like to turn the attention to all of you. Don't allow imposter syndrome to stop you from moving forward. Allow room for self-grace, for making mistakes, for getting back up, for falling down. It all helps us become better at what we do. Getting it done is more imperfect than getting it perfect. Find people that support you when the going gets tough. Create community. And I love this by Brene Brown. You are enough. Mentoring for the future. And this is where I am in my career, where I am working on these legacy programs, or I want to share what I've learned. Share and be generative. Ideas flow in a generative nature, building on one another. So as I shared some of my ideas with you, maybe you thought, oh, I could do that, or oh, I've done that, or maybe I could take it a step further. Like Anne Frank says, everyone has inside of her a piece of good news. The good news is that you don't know how great you can be, how much you can love, what you can accomplish, and what your potential is. It's out there for you to discover. So I want to thank you so much for joining this webinar, and I hope it's inspired some ideas or just reaffirmed how great you're already doing. Here's our different ways to keep in touch. We try and post a lot on social media. And if you had a chance, hopefully I'll look through the comments right now, to share your success. I would like to read it out loud as a conclusion of our program, just to give you all a little time in the spotlight. So let me go ahead and see what y'all have written. Yeah, someone was saying with Medicare, 80% is covered for diabetes self-management education. And many times with Medicare, they'll have a secondary insurance, and the secondary will pick up the other 20%. But if your person isn't able to pay that 20%, what do you do then? And I'll just let you know, we set up a scholarship fund at our hospital where we had a special funds that were donated through our community. We had a walk for diabetes every year, that if people couldn't afford to pay, that scholarship fund would help fill in that gap. Because Medicare says you can't charge some people for a program and give it to free for other people. You have to charge the same amount. So setting up that scholarship fund really helped us. Yes, somebody is asking, in my federal qualified health clinic is asking why DSME matters from a reimbursement perspective. So certain programs, certain rural community programs or federally qualified health programs won't reimburse for group classes. So it may, you know, like where I work, we bill because a provider will see the individual that I see. So that's how they make that's how they're paid for my services. So it really depends on where you're working, what type of service you offer, if it's group or individual, and reimbursement is a big part of that decision. So you can talk to your billing people to get more information. Yeah, so we have a physician from India, and they're working in a place where there's extreme poverty, lack of infrastructure, and lots of providers not using evidence-based. how do you practically start in GLP-1 agonists in patients in these situations, and how do you help get their A1C to target? Right. So if we work in communities where there's a lot of misinformation, there's not a lot of resources, what can we do? And, I've worked in rural situations where what we want to do is get together education and information first, provide that as our framework, and then might start utilizing the lower cost medications, the metformin and the sulfonylureas and the lower cost insulins. And then as we build that momentum, then get attention and see if we can start adding the more costly medications in addition, or maybe reaching out to the pharmaceutical companies directly and say, look, I've got this program. We need support. How can you help? So I would just say start building it, start creating the infrastructure, start measuring outcomes, start identifying gaps, share that information with whoever will listen, and just keep talking and reaching out to the community. Thank you, Lori. Okay. Somebody's asking, is this conference for people training to become CDCS or currently certified? Either way, our live training program is designed to provide people who want to expand their knowledge. It has great updates, especially in pharmacology, but also great for people who want to take their CDCS or BCADM. All right. Okay, let's see what else we had. Amber writes, first month of diabetes education in clinic setting, I had a 76-year-old with an A1C of 8.9, 3 sessions of intervention and CGM added. By 7 weeks, his average A1C was 6.5. It made me feel like I was making a difference. Isn't that terrific? I mean, that's her first month working with this individual, 76 years old, A1C is elevated. By providing these interventions, including CGM, and providing education through nutrition and activity and so forth, that A1C dropped to 6.5. That is making a difference. And not only is it based in, the A1C dropping, this person has more knowledge and feels more empowered to care for their diabetes. So A1C is one measure of success, but this person's sense of empowerment and self-confidence is another just as important measure of success. Jan says, as a BCADM, I was founder and director for an ADCES accredited diabetes program supported by physician referrals in Elko, Nevada from 2000 to 2015. I'm semi-retired now, spending time with grandchildren, but working 2 days a week as a CDCS in a rural IHS clinic. So yeah, terrific. I mean, look at what we can do. And, getting these certifications, BCADM, CDCS certainly acknowledges our expertise, but to set up an ADA or ADCS recognized program, we don't need those certifications. We just need knowledge of diabetes care, and we need to receive information, CEs on diabetes. But I mean, I think being a diabetes specialist allows us to, set up programs, go full force. And then as we get more closer to retirement, or maybe we have kids or grandkids, we want to work less, we can still contribute in a very meaningful way. So thank you, Jan, for sharing that. Keisha wants to know, are DSME and DSMT services covered for patients with prediabetes too? So for people with prediabetes, they would enter a diabetes prevention program. Diabetes prevention programs that are recognized by the CDC are reimbursed by insurance companies and Medicare, but they have to be recognized by the CDC. So you can Google DPP programs, and there's a training program that you need to go through. One of your people needs to be a certified trainer for the DPP, and then you can set it up in your community setting, which would be perfect. Colleen says, I love what I do. I work in a federally qualified health clinic who are supportive and huge support to get a lot done, improve outcomes and patient participation. Love it. I love that. Yeah, I mean, wherever we work, we're going to discover people who really benefit from our services, whether we work in a place where people earn a lot of income or whether we work in more rural communities. People with diabetes oftentimes don't get the care and information they need, and only 5 to 6% of people with diabetes ever get DSME. So our ability to reach out and provide this information makes such a big difference. Will the October seminar contents be available online? Oh, wow. Thanks for asking that, Cynthia. We looked into that. It was cost prohibitive for us. We're, a pretty small company. So no, we won't be sharing it via recording, but we did record our virtual conference in April, which is similar content. So that's on our website right now. So what we're going to do is do one virtual 2.5-day conference online in the winter, yeah, like around February, March. That's really springish. And then do it live in October. That's the goal we're hoping for in the future. So we'll have to see. The live conferences are becoming a little bit more cost prohibitive right now. So, but I'm committed to doing them because they're so much fun. Colleen says, how do I get my patients in private practice to see the value of self-care? Oh, great question, Colleen. I would just explore with them what are their barriers to self-care, because we might have this great conversation and the person seems really amped up to walk 3 days a week, and they come back and they go, I didn't walk. And then we just want to be really kind and loving and non-judgmental, and you might want to say, hey, can you share with me what were some barriers to walking? And they might go, well, gosh, it was because I can't walk in the morning, I'm too busy. And then we start problem solving with them. So what I do is when people are not able to work toward that, well, number one, we have to make sure their goals are super realistic. If people make goals that are so big, they're not able to achieve them, they might feel like failures and just give up. So number one, help people make realistic goals. And if they come back and weren't able to achieve that goal, you say, it's okay, let's do some problem solving together. Maybe it was a wrong goal, maybe it was too big, maybe there's some barriers, but our belief in their ability to engage in self-care is powerful. And it might not be the self-care that we want. Sometimes I might really know, oh, this person needs to do this, this, and this. And then I ask them at the end of the appointment, I go, gosh, what goal do you want to work on? And they come up with something totally different than what I was thinking. That's why it's so important we engage them. And actually on our cheat sheet, I have a cheat sheet page. I have a link to a person-centered approach to coaching that might be super helpful for you, and see if some of those ideas don't help move things forward a little bit more. Christine says, what resources to start a diabetes business to educate patients and families? My area is outpatient pediatric, and I want to move to diabetes care for a rural community. Would prefer to start an outpatient and move to inpatient. Could this work? Yeah. So great question, Christine. And a lot of us want to start our own outpatient program and set up a program to provide this amazing information and education. The biggest barrier is insurance and billing. Those are the two biggest issues. And you need to make sure that whatever you do is based on policies and procedures set out by Medicare and insurance companies. So usually it's easier if you're not dietitians have a lot more success with this than other professions setting up their own standalone clinic. So it really depends on your state laws and what the regulations are. But I would actually encourage you to visit ADCES. ADCES has a lot of resources on starting your own diabetes consulting program, which might be really helpful for you. So kind of looking into your state regulations and seeing what ADCES offers too. Amber says he got the Patient of the Month award, which came with a gift card. Okay, so we're getting back to that gentleman whose A1C dropped. He got a Patient of the Month. I love that. So giving people recognition for their effort, right? We don't want to just focus on the A1C, but giving them recognition for their effort of eating healthy, moving more, being a role model. Boom, you get an award and recognition. How terrific. put their picture in the clinic if it's not a HIPAA violation, and share that with others. It's very motivating. I am starting a program for SMI members with pre-diabetes or newly diagnosed. It is daunting. I am not a CDCS working toward it. Limited funds to attend these programs. Suggestions. I feel like a sponge, but have trouble with the costs. Yeah. So this is a great point. I mean, how do we acquire all these certifications and knowledge? And I would say make a long-term goal for yourself. And, to get your CDCS, it's about 6 months to a year of study and focused study and review. To get the DPP program, it is, to get certified through for that program can be costly too. So you might want to think, what's the thing I want to do first, and how do I approach it, and what would give me some reimbursement early on so I could keep moving my dream forward. And maybe, at first, just to get the funds up, like when I started my own company, I had funds saved up from working in the hospital as a diabetes specialist. So I already had this extra money, and I actually got a credit line from a bank so I could set up my own company and had those extra funds when the finances were a little bit tighter. So I also want to say, anybody starting a new company, you want to reach out to the Small Business Development Center in your area and ask them how to set up a company. So not only do you need information from the diabetes specialist community, you also need information about setting up your own company, which is it's a big learning curve, but it's super exciting. Lisa says, like you, Beverly, I'm excited about being able to mentor and usher in a new generation of diabetes educators. As you noted, we have a lot of work to do, and we need more educators on our team to help support those living with diabetes. Yes, absolutely. That's why we are talking about how great this career path is. CBDCE, the certification board, is trying to raise awareness and get more people excited about becoming certified diabetes care and education specialist. I'm doing my best, lots of webinars, because I am, and I would call myself a diabetes elder, right? I've been doing this for 30 years. I know what it takes to make this happen. It's a lot of work and a lot of study, but each one of us can reach out and say, gosh, why don't you become a diabetes educator? We need more people. Like, you'll see people who have a fire about diabetes that you come in contact with. Let's lift them up. Let's, encourage them to get started in this great career. Beth says, I recently received a grant to implement social determinants of health screening and develop community partnerships to address social determinants of health barriers. Oh, Beth, that's awesome. Yeah. So there is grant monies out there. Another great point. For diabetes prevention programs, there's grant monies out there for looking at increasing access to healthcare services through social determinants of health. Beth tapped into some grant monies there. So I love that. I love this idea because those social determinants of health are truly a barrier to people getting to their best health, right? To receiving care and accessing the services we provide. So that's exciting, Beth. Okay. Anais says, are there available work groups for folks from various federally qualified health program organizations to come together, discuss best practices, and learn from one another? That is such a great question. I haven't seen it. So the Association of Diabetes Care and Education Specialists has special practice groups. And I've seen inpatient, I've seen preventive, I've seen kind of general practice groups. I haven't seen FQHC, but I do know they have had a few workshops on billing for FQHC for diabetes programs. So you might want to check that out. But that's a great group that, like, I would like to be a part of that, because it's a little bit more complicated figuring out what we can provide, what we can bill for versus a traditional inpatient, outpatient setting. Kelly says, I've had a long career of patients who weren't able to attend at traditional programs. I'm not starting to launch my online program, so the location and time constraints don't limit their ability to get info. This couldn't have come sooner. Okay, so I think what Kelly's saying is she is going to launch an online diabetes education program. And many communities throughout America are doing that, and Medicare is still reimbursing for that, and many private insurance companies. So this is a great time to say, can we look at our traditional ways? Like, I've been involved in inpatient programs for a lot of my life, and we, have people come to the hospital setting for classes. It's far from where they live. They want clinics, and they want information in their community are more easily accessible. So I love this virtual. I love getting our programs out in the community where it's easier for people to access and it doesn't feel like a healthcare setting. I think we need to think out of the box and really leverage technology. Thank you, Kelly, for sharing that. Yeah, and some people said maybe encourage self-pay. Some people, especially with diabetes prevention programs, I know a lot of rural areas have had a lot of success setting up programs and charging people a certain dollar amount, and self-pay diabetes prevention programs are another option, certainly. Yeah, Colleen says nurses need to be aware that we are not considered providers, unfortunately. Yeah, what if you have your nurse practitioner, or, if you have your nurse practitioner degree? In some states, they will honor now, that we are providers separately from being part of a clinic, but it's really on a state-by-state basis. Oh, Cynthia says, would love to connect with Beth. I work with SDOH as well. Okay, I'm going to connect you both afterward. I'll email you. Colleen says, not yet. They are working on it. I am involved with ADCES too. And oh, I see. So I think Colleen's saying that ADCES doesn't have a special practice group for federally qualified health programs yet, but they're working on it. Okay, that's so terrific. Liz says, can we do online even if in a big city and people cannot or will not travel for billing purposes? Yes, it doesn't have to be a rural area. So, I mean, I would, double check with all of that. But as far as I know, online courses, if you're a recognized program, can be delivered even in big cities currently. Next month, Teresa says, we will be starting at 6 p.m. telehealth DSME class. We signed 15 people up in the last 2 weeks. Guess there was a need for evening classes for people who work all day. Teresa, I love that. So really looking at what your community needs and providing that through telehealth and the DSME class in the evenings. Great job. Christine says, as to not educating in a typical health setting, I'm wondering if I can do home health visits. Yeah, that's a great question, Christine. I mean, if you're part of a home health organization and you want to provide diabetes education that way, that's certainly something. But you just want to check with liability and insurance before, going into someone's home and providing diabetes education. But see, all of these are great ideas, right? So we don't know which idea is going to stick, which one's going to work, what are the barriers, but we're just exploring it and putting it out there, which is so important. We need more learning collaboratives to learn from each other, says Beth. Yeah, we do need more learning collaboratives. And, if you're a member of the ADCES or special practice groups, there's local meetings with your chapters. So that's one way of connecting with others. Another way is attending live conferences. Like when I was at ADCES, in Houston, a lot of networking took place. But right, how do we build community with each other, and how do we connect and share what we're doing and get insights from others who have already gone through this pathway? Well, I don't see any more questions coming in, so I want to thank all of you for being a part of this first ever Revitalize Your Diabetes Program webinar, and for contributing your successes, for sharing your stories, for asking great questions. And I mean, I think what you have brought up are great issues that deserve further exploration, especially if you have a passion for it. Reaching out to other experts who can help you, reaching out to ADCES, and connecting with others. Mary Jean, hi Mary Jean, says LA County Health Department has established a DSME DPP collaborative and regularly meets to share best practice. Okay, So an example of a local group who has come together, LA County Health Department, to say what is working, what are we doing that's, really effective, and what do we need to change. So I love this. In your community, can you collaborate with others and build connection and, information sharing? Oh, thanks, you all. Well, I so appreciate all of you, and I appreciate you, coming to this program, sharing information, and all the work you do for people living with prediabetes and diabetes. You are certainly making a big difference in so many people's lives. I'm just so happy to be a part of yours for this webinar. Okay, so I'll say thank you. Have a great rest of your day, everyone. We'll see you next time. This is Beverly Tomasian signing off. Thank you.